So as I mentioned, any opportunity to highlight heart failure, especially in the link of ST elevation MI, is a tremendous opportunity. I have a four-fold goal. I want to define the burden of heart failure in 2023, highlight the implications of STEMI on heart failure outcomes, provide a little bit about clinical risk factors associated with heart failure post-MI, and importantly, put forth this concept of early initiation of disease-modifying therapy to minimize heart failure progression as a key opportunity. And so in 2023, heart failure remains common, costly, and lethal. Based on the latest heart disease and stroke statistics, now a little over 6.5 million patients with heart failure in the United States. It's staggering in terms of cost, which I won't go into, but in terms of the morbidity and mortality for these patients, even more staggering, with over 1 million hospitalized patients annually. And as exemplified on the upper right-hand side of the screen, the percent of patients based on percent of population, it's estimated to be about 3% in 2030, but you can see a prevalence as high as over 7% in those over 60. And what's very worrisome when you look at the national vital statistics data, exemplified on the lower right, and look at county level hazard death rates for heart failure going from blue to red being worse in the more contemporary era, 2011 to 2018, 86% of all counties in the United States experiencing increased heart failure death rates. And it's not only in the elderly over 65, but in patients between 35 and 64. Now, it remains true that ischemic heart disease accounts for the majority of heart failure, and we've learned that from landmark publications in the past. We're concerned about coronary artery disease and disease progression, but also sudden cardiac death, and coronary artery disease accounts for the majority of sudden cardiac death. So there's a real opportunity to alter this unfortunate trajectory, and specific to post-ST elevation MI worrisome observations. The heart failure incidence post-STEMI can range from anywhere 4 to 6% up to as high as 28%. And when you look at the Swedish cohort, Canadian cohort, certainly in keeping in that 1 in 4 to 5 patients can develop heart failure not only during the index hospitalization, but further out, certainly at 1 year. And very worrisome in those that are older, the in-hospital heart failure incidence is 3-fold higher. And based on the Dutch multi-center experience, including over 1,300 patients, while they did report a lower incidence, mortality was twice as high as you would expect in those with heart failure compared to those without. And developing heart failure even after that incident event, more than 3 days, a 40+% higher mortality risk. And Greg Stone and colleagues demonstrated that in those patients with a greater infarct size, this is a pooled analysis in 10 primary PCI randomized control trials, those with the greatest quartile or burden of infarct, more than 29%, had a several-fold increase in all-cause mortality or heart failure hospitalization. And even with prompt PCI, about 50% of patients have an infarct size greater than 18%. And that's a 2-fold increase in cardiovascular in all-cause mortality or hospitalization. So very worrisome, and it's not only about death and heart failure, both worrisome outcome adverse events, but stroke and the dysrhythmia burden that can be associated with akinetic and dyskinetic myocardium. This is a particular patient post-MI with an EF 31%. You can appreciate the overt LV remodeling. Now, hospitalizations for us are very concerning. This is in general, and after one hospitalization, median survival about 2.1 years. And when you fast forward 5 years, whether it's heart failure with an EF less than 40% or mid-range or EF preserved, heart failure, hospitalization, and find mortality as high as 75%. And while we certainly know post-STEMI that heart failure, 1 in 5 patients, fast forward over 5 years, maybe prevalence as high as 71%, in particular in the elderly. That was from Justin Ezekowitz and colleagues. There is an opportunity to better study this in terms of hospitalization, post-ST elevation MI, post-index event, and the long-term implications. We would be worried that those outcomes would be poor. So certainly predicting heart failure is an opportunity based on not only understanding infarct size, but biomarkers that reflect wall stress, above and beyond systolic and diastolic dysfunction, microvascular obstruction, The clinical risk factors, I won't go over all of them, but are exemplified here. The elderly, female, I mentioned those two, predisposed to greater heart failure after MI. And so all patients with heart failure certainly would categorize as stage C. We'd follow the standards. During the incident event, we certainly promote ACE and MRA and, when appropriate, beta blocker and up titration. But I think the real opportunity is in all patients with ST elevation and MI, they're at risk for developing heart failure. That's stage A, and working hard to prevent the syndrome would be key. And so when one takes a step back and looks at the factors associated with heart failure, I've mentioned infarct size, adverse LV remodeling based on decrementia. I think there's a real opportunity to improve upon the microvascular dysfunction, which is associated with post-MI heart failure phenotype. And we use this to reflect the trajectory of heart failure, the peaks and valleys. And as a heart failure specialist, avoiding that first trough and potentially modifying the disease would be a real opportunity. And so decreasing the burden and the mortality and the costs based on a team approach, which is the current stance that many of us promote in terms of even preventing heart failure from developing, let alone treating it, is the key. And so take-home points, heart failure, despite contemporary effort, remains common, costly, and lethal. Coronary artery disease and MI remain a leading cause, and 1 in 4 to 5 STEMI patients may develop heart failure. The opportunities include leveraging a forum like this to close knowledge gaps, understanding infarct size, adverse remodeling, and importantly, implementing strategies to avoid the syndrome altogether would be key. Appreciate the opportunity to participate today.
Any questions? We have time for maybe 1 or 2 questions. So those of you who don't know Dr. Estep is the chairman of cardiology at Cleveland Clinic Weston, but also extremely prominent heart failure physician, and coming at this talk from a heart failure perspective. But Jerry, as speaking now as the chairman of cardiology, how can you encourage your interventionalists to get involved with this kind of therapy and recognize the importance of doing everything possible to minimize infarct size, with this kind of treatments?
Yeah, so Dan, I one, thank you for the compliments, but I think it's a true opportunity to understand and leverage that point in time. Certainly one wants to consider all the important aspects of delivering this therapy, understanding the resource utilization, the cost implications. But in the end, Cleveland Clinic mantra, patient is in the center, providing the greatest quality for the greatest outcome and benefit. And so if there is an opportunity to minimize heart failure, hospitalization, improve long-term survival, certainly we're leveraging these other surrogates, then we think it's well worth it. So I think it comes down with recognition, closing those gaps, and understanding that it's well worth it for that individual patient. And all the downstreams benefits at a hospital system level should hold true, right, in terms of minimizing that morbidity and that implication for that patient. So I think it's talking and bringing everyone together. And, this is not just an interventional cardiologist implication. It's an implication for the team. And so approaching it as such, I think, would be important and is the opportunity.
Because really, once the patient leaves the lab,
right,
that's it. I mean,
right,
you're kind of left with what you've got there. If you don't address the problem acutely, it's not going to happen.
Agree completely.